And I noticed that you know the team patient. So Dr. Sarita Shah, who is jointly appointed in global health, and Samita, who is from our point forward of the doctoral program in global health and development. So thank you, and looking forward to speaking. I am class, so I might have to run 10 minutes to the other building.
I think we're going to do this right. Well, come on, it takes World TB Day to get me back on soup and tight. So many of you know, March 24th is World Tuberculosis Day. So for trivia, why do we commemorate World TB Day on March 24th? And those of you who teach this are not allowed to answer. And why March 24th? By weight surgery, by the way. So let's not belabor this. March 24th, 1882, Dr. Robert Koch gave his lecture about the etiology of tuberculosis in the Berlin Physiologic Society. And it was when he announced that this disease that had been afflicting societies throughout the world was caused by a bacillus, which was initially called the Koch bacillus, and later turned out to be Mycobacterium tuberculosis. A few things to mention. This is going to be a team effort. So you've heard from Usha about who the presenters are. But before we launch ahead, I also wanted to use this opportunity to provide you with very brief background. You're going to get TB 101 in 5 bullets. Number 1, TB remains the leading cause of suffering and death. And according to the WHO Global TB Report 2023, 10.6 million people were reported with tuberculosis. Of these, only 7.1 million are identified and treated for completion of therapy. So we miss at least 30% of that burden of disease. And it has to do with the being the second leading infectious killer after COVID. It accounts for 1.3 million deaths in that particular year. It is a leading contributor to antimicrobial resistance, and in fact, either rifampicin or multi-drug-resistant TB account for nearly 500,000 cases, and only about 1/4 of these get identified and treated, mostly because they don't have the diagnostic tests available, and the drugs we are making remarkable progress, but not readily available. Third, we are constantly learning about this millennial disease. We used to think of it as a dichotomous condition. You either have latent tuberculosis or TB disease, and now there's a whole spectrum that goes from infection to disease, which most commonly affects the lungs, but it can affect any part of the body. So you see TB meningitis, abdominal tuberculosis, pelvic inflammatory disease caused by TB, lymph node tuberculosis are common manifestations. TB tracks with poverty. Globally, the WHO shows a very compelling graph with an inverse relationship between TBSs and gross domestic products. And for those of you interested, I invite you to take a look at that graph that is presented there. In addition, there are 5 comorbid conditions that contribute to the population attributable risk of tuberculosis. These are going to be undernutrition, HIV, diabetes, smoking, and alcohol abuse. Innovative technologies are being deployed to facilitate rapid diagnostics. For example, using ultra-portable chest radiographs with artificial intelligence to facilitate the reading without requiring a radiologist that are recorded around the world. And we're really focusing on patient-centered TB prevention therapy as well as curative treatments. So today's seminar is not going to talk about any of it that I said. It's going to focus on the ongoing advocacy efforts and the early yield of these activities. Samita, the floor is yours, and thank you for being here. Go ahead. I'll sit here and say it slowly.
Ken. Hi, everybody. Thanks for joining us. It's very nice to see the full room. And I'm sure many people from the morning. Today, we're going to cover a little bit about background of the UN Living Level Index, the global plan to end TB from 2023 to 2030, and the second UN high-level meetings on TB, which happened last fall, as well as the events and actions that have been propelled from that and how we are staying engaged this week and beyond in this space. So I'm going to start with my own 5 bullet points of UN 101. The United Nations high-level meetings are assembled or convened by the General Assembly, or UNGA, and that is the main policy-making organ of the United Nations. It represents all 193 member states, each of which has an equal right to vote. UNGA provides a very unique space for multilateral discussion where member states can put on the agenda specific issues that fall under the Charter of the United Nations and work towards adoption of a resolution that ultimately reflects in both the highest attainable political commitment from member states, but also concrete measures for cooperation and solutions to global problems looking ahead. Typically, UNGA happens between September and December every year, though probably you will have all seen that it's very pronounced with high-level meetings and public-facing events in September in New York. Since 2001, the UNGA special session on HIV/AIDS really propelled action for health over the next 20 years and what we're seeing today. But we've only had 6 health topics that have been presented in that form. That includes HIV/AIDS in 2001, and again in 2006, 2011, 2016, and 2021. Non-communicable diseases in 2011, 2014, 2018. AMR 2016, and again, AMR will be the focus of 2024's high-level meetings. TB, which happened in 2018 and again in 2023. Universal coverage, which happened in 2019 and 2023, and then pandemic preparedness, prevention, and response, which happened last year. So there's a lot of scope still for many of the health issues that we work here on at RSPH to be addressed in that space, and clamor for in terms of advocacy, funding, and research. So why should we care about this? I think we know intuitively from our research and from the work we're doing that draws us to public health and global health that political commitment is essential for translating research into practice, ultimately so that we can see the change we want to see in improving care, treatment, and quality of life for the patients and communities with which we work. Policy informs the research agenda in very direct ways. It affects how the funding environment looks, and what types of opportunities are available for us to actually do the work resource-wise, what uptake and sustainability of service delivery looks like, and what the dialogue around health looks like as well, and how that affects care seeking, stigma, and access to service. We have the unique opportunity where we're one of 5 academic institutions that are approved to participate in what is otherwise a very rare gathering of global actors. And I think that space really moves us to see the opportunities that are available. Some of those are connecting with member states, connecting to understand what are their priorities in the health agenda and how can we work with them and implementing partners to be able to advance that. It also allows us to connect with health champions and individuals with lived experience who ultimately are at the center of this dialogue and need to have their voice heard and what the research and practice agenda should look like. It enables us to engage on issues beyond just the health of persons or beyond just TB. So how do we think about policy? How do we think about advocacy? How do we think about stakeholder engagement and commitment? And then importantly, influence with a direct line what the research envelope needs to look like. What does the agenda for research and practice need to look like, and how can we inform that in a chorus of voices to get the right people to hear it? Lastly, and I think specifically for TB, which coincided with universal health coverage and pandemic preparedness, prevention, and response last year, is the opportunity to really align platforms with other health sector priorities. So both for funding, for service delivery, but also for advocacy. How do we work across these lines and make sure that we have one clear message about what people ultimately need at the end of the day at their point of care? TB high-level meeting coincided with these, but I think there were still opportunities to advance that integration approach further. So how is the UN high-level meeting linked to TB? So this campaign for the high-level meeting for TB started in 2016, but then chaired of the Stop TB Partnership and the Minister of Health for South Africa. And it was a process where a number of member states had to get together and advocate for a space on the docket in the upcoming high-level meeting agenda, which is, by short way of saying, not easy to get. People are waiting for years in line to have a spot, to have a high-level agenda, a high-level meeting, and an agenda that follows from it. So through a resolution, they were able to agree on 2018 being that opportunity for the TB high-level meeting, and work together to develop this political declaration that was endorsed by the highest representatives of all member states, whether they're presidents or prime ministers of heads of state, to come together on key targets that allow for the advancement of TB elimination and the goals of the TB elimination roadmap. So these commitments and targets, both were there at a global level, but then also followed with national level plans for each of the unique contexts to be able to follow through on what they're working. Broadly speaking, the TB commitments and targets for 2022 cover 3 areas: treatment, prevention, and investment. For treatment, really looking at successful treatment of people with TB and drug-resistant TB, including children. For prevention, advancing TBT, which is prevention therapy for at least 30 million people, including children and including those with key comorbid conditions like HIV. And then increasing global investment as it relates to the diagnosis, prevention, treatment, but also R&D. Lastly, the commitments really look forward to having accountability measures from member states to be able to follow through on these protocols. As we can see, there's a lot of progress made towards the 2022 targets and commitments. We've had more than 75% of progress in the treatment area, and at least 50% in prevention. Still considerable progress in universal access to TB prevention, diagnosis, treatment, and care, with about half of the funding asked for TB research put forward. I think it's very clear that there are still gaps remaining from this table, and that's one of the things where, as the 2022 targets are evaluated as the 2023 high-level meeting has picked up, that there is a refinement of the targets and advocacy needed to be able to get across to newly defined questions. The larger picture of some other forces that affect meeting these targets, I think, are quite obvious in some sense, but COVID-19 in the last few years has been a very unique threat that has changed the way TB diagnosis and care seeking has been able to unfold. Lack of funding seems like a perennial problem, but it has become more pronounced as we have had an increasing number of competitive priorities in the global health landscape to be able to fund for. A lack of access to the latest diagnostic tests, which again alludes to the interest in R&D investments as well as treatment, prevention, and diagnostics. And then slow rollout of TB prevention, which links back to also health system strengthening capacity of health systems to be able to follow through on these plans. To provide a little bit of context, I think COVID is a great example where we can really see in the 2022 data, and probably more recently with more information that's come out, how countries have had to reallocate resources to be able to address COVID, and as a result, take them away from already limited funds that were going towards TB care. And there's an increasing number of reporting pathways and opportunities for us to better understand in what specific delivery ways that has happened. And this one further shows that is that I think at the time of COVID, you can really see this drop in reporting of numbers of newly diagnosed TB cases. But that has recovered quickly as we've gotten a better hold on COVID and tried to reallocate and restore health service delivery across other sector areas. but that recovery is still only partial to what was lost in that time frame, and that there's still a lot of work there to make sure that as these emerging threats come into the picture, we don't lose sight of or are unable to manage the existing priorities that we already. And lastly, to take that point home, I think what we've seen in the data as well is that mortality is continuing for TB, and that it still represents a pressing threat that we have to attend to, despite the fact that reporting has been altered by other health priorities that have emerged. With that, I will pause and finish.
Thanks, Abby. So continuing with the choreography here, after the last UN high-level meeting, the global community came together, assembled scientists, researchers, practitioners, and in fact the communities then came up with this global plan to end tuberculosis, looking at the years 2023 to 2030. The plan is meant to accelerate progress aligned with the WHO NTB strategy from 2014 and the UN Sustainable Development Goals. It focuses on diagnosis, treatment, and care for people with disease and infection. It also focuses on the need to fund research for new medicines, treatments, diagnostics, and vaccines, and starts setting up some targets, such as aspiring to treat the 95% of people with tuberculosis, diagnosed and get treated. And the modeling that was done to come up with these figures show that if you meet these targets, you'll see an 80% decrease in incidence per 100,000, as well as a 90% decline in annual deaths by 2030 compared to 2025. How much? There's a price tag to this. It's nearly $250 billion. And before you experience sticker shock, if you calculate that based on approximately 8 billion population, it's about $31 per person globally. The breakdown is to use 157.2 billion for prevention and care, scaling up modern diagnostics, expanding early diagnostic efforts, integrating screening and testing to other health services, and find the undiagnosed people with TB and make sure that we treat to cure. Another close to $93 billion devoted for research with the rollout of new vaccines. Of this, $40.2 billion to accelerate the development of the new tools, diagnostics, treatment regimens, detection and treatment of drug resistance. And I alluded to this in the introduction. Happy to talk about this later. Then 53 rounding up billion for vaccine research and delivery, and once a new, safe, and effective vaccine is available, make sure that we provide it to people who need it the most. Currently, there are 17 candidates in pipeline. 6 of these are in phase 3 trials, and that right-hand lower corner shows the pipeline of TB vaccines. It's not legible, but once you get the slide, you can zoom in and you can see that. And you can see that 6 of these are in phase 3 trials. And in fact, last week, leading up to World TB Day, we heard the announcement that the Bill and Melinda Gates Foundation is starting right now a phase 3 trial in South Africa, and it's going to include other countries. The anticipated gains or the return on investment is that funding from governments, development banks, and philanthropic organizations all together would get $40 for every dollar invested. If you then look at what would happen in lower income and lower middle income countries, the return is even higher, as high as 59 for every dollar invested. So you really have a very compelling case for the investment. Another really important component included in the plan is what happens with inaction. If you fail to do anything about this, you'll see an additional 43 million people with disease and 6.6 million deaths at a cost of $1 trillion. So inaction is not something that we think is admissible.
Can I interrupt you? Can you go back to the last slide? I'm reminded of the slide you had in your talk last week when you spoke at UCSF of the excess cases that occurred in the U.S. as a result of the resurgence in the early 90s due to HIV. I wonder if we could reframe a slide like this to say the blue line is where we should be.
Right.
And if we stay on the red line, those are excess cases that cost the world how much.
Absolutely. In fact, you're right that we did that when we experienced the resurgence of tuberculosis in the U.S., where there was a reversal after more than 3 decades of steady downward trend. Cases went up between 1985 and 1992 by 20%. And we calculated at 52,100 TB cases that should have never occurred. As our regional trends continued, we're seeing. So yes, I agree with Neil that those are good ways to make an even more compelling case. So to finish with the global plan, these are the resources that need to be mobilized in summary. And as you can see, there are milestones for each cluster here. So from 2023 to 2027, deliver treatment to 38.6 million persons. Between 28 and 30, treatment to 1.4 million, including children, and 500,000 persons with multi-drug resistant TB. Deliver preventive therapy during 23 to 27 to 16 million, and TB preventive therapy in the latter 2 years to 19 million. And there's a footnote here. The revised targets will be needed if we fail to meet these. You can't keep chugging along if you fail to get the work done. With that, in the choreography, Dr. Shah is next. Thank you.
Okay, thanks. Thanks to my previous 2 colleagues for setting the stage for the 2023 high-level meetings. So you heard why high-level meetings are important, what they can achieve. You heard about the plan to get us to end TB by 2030. And so a large part of that was the price tag, setting targets, getting political engagement and buy-in. And the high-level meetings are the place to do that. So what happened? In 2023, we had the UN high-level meeting on TB, and this was in New York, and it had the specific focus on advancing science, financing, innovation to end the TB epidemic by ensuring equitable access to prevention, testing, and treatment. And so we reviewed where we were based on the targets set from the first high-level meeting, and then looked at where we needed to go to meet the UN Sustainable Development Goals. So we talk a lot, I'm sure in a lot of your classes, a lot of your work, you talk about political will, political commitment. Often it's lacking. That's why things don't get done, right? It's either lack of political will or so again, the high-level meeting is a place to get that political commitment and buy-in. So the high-level meeting had over 125 ministers and country delegations. There were statements made by heads of state, usually ministers of health from all of the participating countries, to make a statement of their commitment to what is being put forward in the political declaration. So they're making this very public commitment. That's where it starts. And then, of course, a large participation by civil society and other stakeholders, including Emory, which was one of the only 5 academic institutions accredited to participate in the meeting. And so as we gear up for a high-level meeting, there's a lot of things that happen before you get to September and that moment. And so I'm going to kind of take it back a little bit through the calendar year before we got to the high-level meeting. So in the lead up to that, one of the big things, there are several things that occurred. The WHO launched the TB Vaccine Accelerator Program. Many of you may know that we have a vaccine for TB. It's 100 years old, and it works really only in the youngest children for preventing severe disease. We don't have anything that works in adolescents and adults who are the ones that are primarily developing TB and responsible for transmission. Kind of a huge need for TB vaccine, and the TB Vaccine Accelerator Program was announced in January to really accelerate vaccine development. You've heard about the phase 3 trials that are going on. And we saw what happened when the world invested in a COVID vaccine. We got one very quickly. So this was part of the lead up and trying to build on that momentum and political commitment in the high-level meeting. Also leading up to the high-level meeting, there is sort of a draft resolution, but there's a lot of feedback that's invited and ideally incorporated into the resolution from various stakeholders. So in May, Samantha actually participated in this. There was a multi-stakeholder engagement or hearings on PB to hear from affected communities, TB survivors, other stakeholders on what is really needed, in addition to what's outlined in the plan, what's needed and what needs to be in this political declaration to achieve the goals of ending TB. And so that is a really large forum to have voices heard of people really putting forward what it is they think needs to be in that declaration. And again, I know this might feel a little bit like abstract, like what is a high-level meeting, what is a declaration, maybe it's just a piece of paper. It is at the end of the day, you have to have a lot of links here. It is, a declaration, a piece of paper or a file, but what's contained in that. And so that's why there's so much that goes into developing that, because what is in there is what countries are committing to, what targets can be developed, what funding can be put forward, and what's going to get done at the end of the day. So this is the political declaration that was approved in September at the high-level meeting, and it means that the countries are signing on. They're saying we are committing to do this. That's the first step in getting something done. And so these were the most ambitious targets ever set forward. They're very comprehensive, time-bound, and I'll go into a little more specifics as they break it down country by country and year by year. And the goal was to provide equitable access to TB services, addressing human rights and other TB social determinants as part of the approach. So specifically, it includes, like I said, targets for diagnosis and treatment. And where do these targets come from? Comes from the global plan. What is needed? That plan comes from modeling and gaps and all of what's going to get us towards ending TB. So these all kind of link together and come to the point of the high-level meeting. Really strengthening the language on developing, rolling out a TB vaccine. I mentioned the accelerator program. There's not exactly a great target on vaccine, but there's at least mention and commitment toward vaccine development. Recognizing the gendered impact of TB and including gender-responsive, gender-based approaches to diagnosis, treatment, and prevention. Emphasizing the multi-sectoral approach to addressing social determinants. Sammy mentioned at the beginning, actually I think it was Ken mentioned, the 5 main drivers of TB. TB is curable. We have medications. We have vaccine, not great, but we have this tool to get TB. It's still the leading infectious disease cause of death. Why is that? Not because of the medications. It's really because of all these other underlying factors that are not being adequately addressed: poverty, nutrition, stigma, housing, and that is really brought out in the political commitment to have this be a really multi-sectoral approach, and then a commitment to social benefits package. So these are the targets. Again, I feel kind of dry as a table. What does it mean? 90% treatment coverage, 90% coverage for TB preventive treatment. Everyone should have access to a rapid diagnostic test. That's a big commitment. And as Ken mentioned, right now, 30% of people with TB are not even being diagnosed. Out of 10 million, only 7 million. So there is a commitment here to have 100% of people having access to a rapid diagnostic test for TB. Mentioned the health and social benefits package for 100% of people with TB. New TB vaccines be rolled out, preferably within 5 years. And then funding that is put forward here, $22 billion by 2027 and $35 billion by 2030. So these are all derived from the costing that is put into achieving the targets and then funding for research. Like I said, these were the most ambitious targets put forward to date for TV, and it's hope that it is supposed to put us on track to ending TV by 2030. So just breaking down all of that into some numbers that we try to keep at our fingertips. The commitment is for 45 million people to be treated for TB and 45 million to be provided with TB preventive treatment, broken down a little bit more into the vulnerable groups for children and people with drug-resistant TB, contacts, etc. What does that look like? Those are really big numbers. How do we really get there? It's broken down with country-specific targets that are assigned and that are split out by year. So it is a team effort. It is the entire world that has to work together to achieve these extremely ambitious targets, and can't be done unless each country does its part, right? So this is a document from the Stop TB Partnership that disaggregated the global targets by country and by year, taking into account incidents in that country, etc. And this is just a snapshot from here, but it's a really great. I don't know, people that like kind of looking at numbers. It's a great document, and it really splits out those targets and makes it very concrete as to what each country is trying to achieve by when, so we can all together meet these ambitious targets. So I just kind of put a snapshot here. It starts from first set of countries and letter A, and it goes all the way to letter Z. And at the bottom, it totals it up to say, if everyone meets their annual targets over time, we will treat 45 million people with TB. This is how it's going to get done. And this is really happy. It sets a plan and a timeline, and countries are going to be supported and monitored in their progress towards these targets. And then, of course, those need to be revised if they're not meeting them, or if something happens when there's like a dramatic change in incidents or whatever. So the political declaration was really met with a lot of enthusiasm. It was signed off on, and it's really wonderful and ambitious. Like I said, there are some gaps, of course, that people wanted to see and didn't come through. And there's just not, there often is negotiating that happens and things fall out. So the accountability to the monitoring and follow-up was not felt to be as strong as it could have been. There were some things that were not fully addressed under social determinants in terms of like actually having concrete targets. And those who've got working programs or are going to work in programs, targets are what programs are working towards because it's what they get measured on. It's sort of like getting a grade. You know what you need to do, or you have a rubric, and if it's not, indicated there specifically, it like kind of gets done, but doesn't exactly get done perhaps as well as it could be. And then the lack of the community rights and gender action plans was another big area that was left out. So around the high-level meeting, because there's so much attention on this issue, there's a lot of mobilization that happens, a lot of commitments, not just by government, but by other entities that participate in the TB response. And so I'm going to share with you some of the things that happened around the UN high-level meeting. So one of them is the Kochana Award, which is supported or is administered through the Stop TB Partnership, and it recognizes the importance of communities and civil society in the response. And this year, the award went to two institutions and an individual from the Ukraine that were heroically continuing TB service delivery despite the ongoing war there. It was a really moving tribute and really inspiring to recognize the work that they're doing and the importance of community and civil society in the TB response. So really spotlighting that. Other big announcements, USAID, you may have heard even last week, there was a big announcement by them following on this from September, committed $23 million to their Global Accelerator program. Of this, $15 million is going to the Philippines and Ethiopia for their SWIFT TB initiative to roll out TB innovation, including things like portable AI-based chest radiography for identification of TB. So if you look at it, there's just a lot going on with that. And then supporting TB in conflict settings. I mentioned Ukraine, but also Afghanistan and Burma. We're going to go into more specifics on negotiated price reductions. So it's hard to imagine, but it's hard enough to get diagnosed with TB, but a lot of people don't have access to the treatment at a reasonable cost in our country so that they can get the treatment they need. So negotiating price reductions, again, seems really boring and dry. Why am I in public health dealing with price reductions? But that's how people get treated for their for what it is they have. I'm going to go into that. And then there's investments in new and simpler regimens for TB prevention. The BREACH TB trial is looking at just a kind of injectable form of TB prevention. We have injectable forms of HIV prevention. People often ask me, why don't we have injectable forms of TB prevention? So we're trying to commit to working towards that, and then committing funds to local partners. Another set of large announcements by PEPFAR, which is the President's Emergency Plan for AIDS Relief, committing to finding some of those missing cases, so increasing detection of over 2 million cases and preventing 500,000 deaths. So there's 1.3 million deaths each year. This is the commitment to bring that down through active case finding, developing actual concrete plans to enhance case detection and reduce mortality. Government of Canada committed $25 million to TB REACH, which is a program that is administered through the Stop TB Partnership and goes, to programs all over the world for improving service delivery. And I won't go into some of those specifics there, but just to give you a flavor of how countries come to the table when there's a high-level meeting and really make these commitments to improving TB treatment, prevention, and care. So this is a price reduction I mentioned. 3HP is a 3-month regimen for TB prevention. Prior to this, it's been really what's used mostly worldwide as a 6-month regimen. The isoniazid, so it's 3 months, cuts it in half, and it's only 5 days a week that you have to take that treatment. And so there was a price reduction a year before the high-level meeting, bringing the cost down to $14 for that 3-month regimen. And then in September, there was a further reduction to just about $10 for that regimen. And it's not that the patients or people have to pay for this, it's that countries that have to buy those medications can now, they have a set amount that they're going to spend on this issue. And they can buy more treatment regimens because it costs less. And so that's how these price reductions translate into more people receiving preventive treatment. So it was, phenomenal price reduction.
You done?
Okay, good. Another really exciting announcement was reduction in the price for bedaquiline. So bedaquiline is one of the new drugs approved for treatment of drug-resistant TB. There are two primary pharmaceutical companies, J&J and Lupin, that agreed to lower their prices by 55% and 43% respectively, which brings down the price of a 6-month treatment course to around $130 to $200 for treatment, depending on who they're purchasing from. And this is compared to the previous price of nearly $300 for a 6-month course. So this is a huge advance in negotiating that price reduction. So again, almost double the number of people we receive that treatment. That's an all oral-based regimen, less side effects, shorter duration, high cure rates. And the other important thing that came around the time of the high-level meeting was that J&J agreed to non-enforcing secondary patents. So their primary patent had expired in July, and they had, there was a lot of advocacy and public pressure to have them non-enforce a secondary patent, which means that access for patients is much easier. In the diagnostic space, so we talked about prevention, treatment. In the diagnostic space, there was also price reduction negotiated on the Gene Expert cartridge. This is one of the primary methods used for rapid diagnosis of TB and drug resistance. And that price came down as well, again, with public pressure to bring that down to just around $8. So I've mentioned it a few times, but I really want to highlight the impact, the effectiveness of public pressure and advocacy on all of the things I just shared with you on bringing down the cost of the GeneXpert cartridge test, on not enforcing the secondary patents. And the work is not done. We're not saying, okay, this is great, but not right. There's still a lot more that needs to be done. And there is a movement for, and a petition you can sign if you want to go online, really pushing for reducing the price of the expert cartridges to $5 to increase access to the people that need it so that people can be diagnosed and put onto treatment and then hopefully reduce the spread of TB. So I encourage you all to get involved in whichever way, speaks to you. But it can and it does have a palpable impact. So that was really inspiring. And I think with that, I'll also just share with you several of the events that are going to be taking place in the next. And tomorrow, actually, all of these are tomorrow. So you can wake up in the morning and start your day with the infectious disease seminar being given by Cheryl Day, talking about immunity across the lifespan. And why is that important? Understanding immunity for controlling TB, for vaccine development, all of that. If you're interested in getting involved in TB, we have a lunchtime panel that will talk about a variety of different ways you can develop a career path in TB. And then at 4:00, we are thrilled to be hosting the author, Maria Milios, who wrote The Black Angels. It tells a story of nurses in the pre-antibiotic era that were providing care in New York City. And she will be here to tell us about their story, about her journey in writing the book. And you can also buy books. And she'll be signing and you can join us for the reception afterwards. So with that, we have some time for questions. And just want to thank everyone. It's great to see a packed room here and to all of you online, and hope you'll get involved. Thank you so much. Okay, thank you for sharing that in the chat. You can maybe send that out. We'll send out the funds.
It's 22. So it does. Employers are not feeling class.
Yeah.
Can you comment on, when we have the dynamic meeting where we focus on the CD, the last slide, it's embedded in SVG. So could you comment on how that integration was made with the STDs? I've sent several of them and then they have some names, etc. And were there any specific SDGs that ally more closely worked on as countries are aiming for TB reduction? And
I mean, my favorite SDG, maybe everyone has their own favorite SDG. My favorite is SDG 1, which is poverty reduction. I think that aligns most politically with what we've seen are the drivers of TB, and what we've seen allow TB to turn around in places that have a lower burden of TB is really addressing. Partly, what's that mean? That means, reducing household crowding, right? Improving access to, food, reducing food insecurity, right? All of those types of things that are the drivers. So I guess if I had to say, I think that there is finally, there is a lot of attention on the underlying social determinants because, again, like I said, we have the drugs that are curative. That's not the gap at the moment. Of course, we can get them cheaper and diagnose people faster, but really the social determinants. I think that's the one I would say was really being integrated into it. I don't know if Ken or Sam want to answer that.
But I would add the other two that are gaining a lot of traction is linking this to universal health coverage. I mean, many of these people are experiencing catastrophic costs to just getting diagnosed with TB because they take transportation, pay for the x-rays. Then maybe once they're diagnosed, the program might provide them with no-cost drugs or not out-of-pocket costs. Someone pays for them. So that's the other one. And the one that was included in the 2023 is the pandemic prevention, preparedness, and response. You saw that Sunita showed one slide where many of the TB resources and employees were repurposed to do the COVID response. Not surprisingly, we deal with an airborne disease. We do contact tracing for a living, and we make sure that people who are on treatment get to take the drugs the way they should, and try to also monitor for side effects. So the world is predicting that the next pandemic is likely to be of airborne nature. So in that setting, there's also that conversation taking place. And, pandemic preparedness, I don't think was part of the original Sustainable Development Goals, but it's certainly a new occurrence that merits attention.
Okay, thanks everyone.
Anyone online?